Oh, welcome to Learn from the Case. How are you? Today I want to propose to talk about amyloidosis. Here we will see more than anything primary amyloidosis, and soon also the other types. Amyloidosis constitutes a heterogeneous group of diseases characterized by the extracellular deposit of autologous fibrillar protein material and with a very specific molecular structure, which is known as a tertiary molecular structure in beta plegated disposition. This characteristic molecular structure of the amyloid substance is responsible for the insolubility of amyloid deposits and their resistance to proteolytic digestion. As a consequence of the molecular stability of the amyloid fibrillar protein, the amyloid deposit progressively causes the replacement and destruction of the parenchyma in the affected organs, causing various functional alterations depending on the location and intensity of the deposit. The term amyloid is due to the fact that it is similar to cellulose or starch, staining with iodine and sulfuric acid. Although currently Congophilia or positivity to Congo red is the criterion used to diagnose the disease. The amyloid substance is basically formed by the amyloid fibrillary protein, which will define each variety of amyloidosis, the amyloid P component common to all varieties, glycosaminoglycans, heparin sulfate, proteoglycans, and calcium in minimal quantities. To date, more than 50 different fibrillary proteins have been described with the ability to develop amyloid deposits. Classification. Amyloidosis can be classified based on the distribution of amyloid deposits in localized and systemic forms, and the constituent fibrillary protein specific to each variety. The terminology used in the classification of amyloid disease includes two letters. The first is A for amyloid, and the second letter refers to the specific fibrillar protein or important clinical criteria. EA amyloidosis, light chain amyloidosis, also called primary amyloidosis, which we will see in this video. Soon we will exclusively delve into this type of amyloidosis. AA amyloidosis, it corresponds to the forms of secondary amyloidosis linked to chronic inflammatory processes of infectious, immunological, or neoplastic origin, including in this group the amyloidosis associated with autoinflammatory diseases, familial Mediterranean fever, tumor necrosis factor receptor associated periodic syndrome, syndrome associated with a tumor necrosis factor receptor, cryopyrin associated autoinflammatory syndromes, hyperimmunoglobulinemia D syndrome, pyogenic arthritis, pyoderma gangrenosum, and acne. AF amyloidosis. Under this name are included several forms of hereditary autosomal dominant amyloidosis, mainly familial amyloid polyneuropathy, and the cardiomyopathy variety, Danish type. AH amyloidosis. Hemodialysis-associated amyloidosis is a variety of systemic amyloidosis described in patients with end-stage chronic renal failure, which are undergoing long-term, more than 5 years, dialysis replacement therapy, particularly hemodialysis. Elect 2 amyloidosis correspond to a variety of systemic amyloidosis recently described in the Hispanic population, with renal and hepatic involvement. The amyloid fibrillary protein is LECT2, leukocyte cell-derived chemotaxin 2. The etiology is unknown, with a suspect genetic component due to the racial predominance and aggregation in some polymorphism. Another classification is that of localized forms. This group includes varieties of amyloidosis with localized or selective deposits in certain tissues or organs of a local nature. Endocrine amyloidosis, these are localized form of amyloidosis related to endocrine tumors, in particular of the APOD, amine precursor uptake and decarboxylation system. There is an intimate relationship between the fibrillar amyloid protein characteristic of each variety and the hormone synthesized and secreted by the tumor. The most common variety is that associated with calcitonin secreted medullary thyroid carcinoma. In patients with type 2 diabetes mellitus, amyloid deposits are found in the islets of Langerhans in more than 90% of cases. The deposit fibrillar protein is islet amyloid polypeptide, also called amylin, secreted together with insulin. The pathogenic role of amylin deposits is unknown, but they probably actively participate in the development of type 2 diabetes. It can also be classified as senile, cerebral, cutaneous, amyloidosis, etc. In this video, I want to talk specifically about AL amyloidosis, which is primary amyloidosis, light chain amyloidosis, hence the L. I want to present a case from the Spanish journal Internal Medicine Clinical Cases that they call fulminant hepatitis in a patient with primary amyloidosis with complete hematological response. They present a case of a 41-year-old male with non-known toxic habits with a history of chronic HCV, genotype 1b infection, without secondary liver disease, treated 2 years earlier with onbitazvir, peritapavir, ritonavir, and decivovir, obtaining a sustained viral response. 4 years ago, he underwent left radial nerve transposition and remained on NSAIDs, non-steroid anti-inflammatory drugs, and tapentadol due to poor post-operative pain control. He reports non-relevant family history. He seeks healthcare for episodes of abdominal pain accompanied by watery diarrhea without pathological products and alimentary bilious vomiting for 3 months. He had not had weight loss or macroscopic digestive bleeding. In the last 24 hours, he reported the appearance of edema in the lower limbs and scrotal sacs, without associated voiding syndrome, oliguria, dyspnea, or other symptoms. On physical examination, he was hemodynamically stable, in good general condition, apneic, and afebrile. Cardiopulmonary auscultation showed hypophonia at the lung bases, abdomen without acidic semiology, or other findings, and pidgin edema up to the roots of the lower limbs, and scrotal sacs. As additional test, result from the blood test: hemoglobin 17.4 gram per deciliters. The reference values relating to the laboratory that performed the tests are present on the screen. Biochemistry with normal renal function, and so with ionogram and liver enzymes. Total protein 4.3 grams per deciliters, and dyslipidemia with total cholesterol 447 milligrams per deciliters. LDL 308 mg per deciliter, and triglycerides 245 mg per deciliter. Serum troponin I levels 1.4 micrograms per liter, and pro-BNP 50,368 picogram per milliliters. Hepatitis B virus and HIV negative HCV viral load was undetectable. Autoimmunity study ANA, ANCA, anti-PLA2R antibodies, antiglomerular basement membrane antibodies, complement, immunoglobulin count, cryoglobulin determination, and RF was normal or negative. Chest X-ray was performed and was normal. Electrocardiogram showed sinus rhythm at 100 beats per minute with low voltages, with R that was less than 5 mm in limb length and less than 6 mm from B3 to B6. And 24 hours urine analysis revealed proteinuria of 2.76 grams. Renal ultrasound showed hyperechogenicity of the renal parenchyma and loss of corticomedullary differentiation. Bone marrow biopsy revealed a regular plasmacytosis with areas with infiltration up to 20% with co-expression of CD138 and CD56 positive. Serum free kappa light chains are quantified in 14 mg per liter, free lambda light chains 178 mg per liter, kappa lambda ratio is determined in 0.08. Renal biopsy revealed findings consistent with light chain amyloidosis. Abdominal fat biopsy was performed, which was negative for Congo red staining. Echocardiogram showed increased wall thickness and mild pericardial effusion, suggestive of incipient infiltrative disease, without evidence of restrictive cardiomyopathy or diastolic dysfunction. Nephrotic syndrome was initially diagnosed, and treatment was started with enoxaparin, an antiproteinuric drug based on enalapril and furosemide, and atorvastatin. The patients developed diarrhea and vomiting that prevent his intake, which caused him to lose 8 kilos of weight in a month, accompanied by increased edema of the lower limbs and frank ascites without pleural effusion. Treatment is associated with amiloride and hydrochlorothiazide. An abdominal ultrasound was requested, and a liver with diffusely increased echogenicity was found in relation to steatosis without focal lesions. Patent splenoportalysis, abundant intra-abdominal anechoic free fluid is identified in the perihepatic, perisplenic, pelvis, and, to a lesser extent, in both iliac fossa. In addition, a colonoscopy up to the ileocecal valve was performed without significant findings, and colon biopsies were performed which demonstrate the presence of deposit of amyloid material with immunohistochemistry negative for amyloid A protein and positive for lambda chains. The patient begins with signs of dysautonomia due to arterial hypotension and erectile dysfunction, and presents with complete bilateral peripheral facial paralysis. The study is extended with cerebral and cervicofacial magnetic resonance imaging, where an increase in adipose tissue is observed in the cervical and supraclavicular compartment bilaterally. Chemotherapy treatment was started with a cyborg regimen, cyclophosphamide, bortezomib, and dexamethasone, without achieving a response after 3 cycles. Second-line treatment with daratumumab was started, achieving a complete hematological response after 4 cycles. Despite achieving a hematological response and triple diuretic therapy, the patient developed anuria, severe hyponatremia, and rapidly progressive acute renal failure. Hemodialysis treatment was then started. Suddenly, the patient developed hyperbilirubinemia, recurrent hypoglycemia, hyperammonemia, coagulopathy, refractory ascites, and decreased level of consciousness. Possible chemotoxicity and infectious etiology of this liver failure were excluded. Finally, the patient died 10 months after the clinical onset of the disease. The diagnosis was primary amyloidosis with fulminant hepatic failure. Discussion and conclusion. Primary amyloidosis is a heterogeneous group of diseases characterized by amyloid deposition in tissues and organ damage. The heart and kidney are the 2 organs most frequently affected by primary amyloidosis. Other organs affected are the gastrointestinal tract, peripheral nervous system, and autonomic nervous system. And they say our patient present data suggestive of digestive tract involvement, abdominal pain, diarrhea, vomiting, diarrhea being the most frequent gastrointestinal manifestation, and may be due to both digestive tract involvement due to amyloidosis and the development of amyloid dysautonomia. The most frequent clinical form of renal involvement in primary amyloidosis are nephrotic syndrome and rapidly progressive renal failure, both of which developed in our case, which are fundamental in the diagnosis process, and both were documented histologically. The patient also presented data suggestive of cardiac, hepatic, peripheral, and autonomic nervous system involvement. Liver involvement is reported in up to 70% of autopsies of these patients, and most are asymptomatic. The most frequent symptoms are weight loss, asthenia, and abdominal pain. Less frequent are anorexia, early satiety, nausea, or dysgeusia. On physical examination, it is common to find hepatomegaly and less frequently ascites or splenomegaly. Cases of hepatic amyloidosis are associated in 70 to 18% with nephrotic syndrome, congestive heart failure, orthostatic hypotension, and peripheral neuropathy. Very rare manifestations include portal hypertension, spontaneous liver rupture, and acute liver failure, usually in the form of progressive intrahepatic cholestasis. It says here that all these manifestations are associated with high mortality. In case of acute liver failure, therapeutic options include treatment with dexamethasone, melphalan, and bortezomib, as well as liver transplantation. Both acute liver failure and rapidly progressive renal failure, even with the need of renal replacement therapy, are 2 situations described in these patients. Despite achieving a complete hematological response, this patient developed fulminant liver failure and died. They described, "We do not have a liver biopsy to confirm amyloid infiltration in the liver, but it is a known complication, although it is not clearly described in the literature in patients with complete hematological response." So, to specify a little, primary amyloidosis, or AL amyloidosis, light chain amyloidosis, is the most commonly diagnosed form of the disease and represents 85% of all cases in developed countries. In primary amyloidosis, the fibrils that make up the amyloid substance are made up of a variable portion of a line change, kappa or lambda. The light chain is more often lambda than kappa, ratio 2:1. The annual incidence is 0.9 cases, new cases, per 100 inhabitants per year. The most common symptoms are fatigue and weight loss, dyspnea, edema, paresthesias, syncope, orthostatic hypotension, or changes in voice tone may also be observed. 1/4 of cases have hepatomegaly and 10% have macroglossia. Purpura on the face and neck, particularly the upper eyelids, is a common finding. Syndromes associated with primary amyloidosis include nephrotic syndrome, carpal tunnel syndrome, congestive heart failure, peripheral neuropathy, and orthostatic hypotension. Less common manifestations include malabsorption syndrome and giant hepatomegaly. The presence of any of these syndromes in the presence of a serum or urinary M component is highly suggestive of primary amyloidosis. Congestive heart failure occurs in about 30% of cases. Electrocardiogram frequently shows low voltages and arrhythmias. Echocardiogram or cardiac magnetic resonance imaging are very useful techniques in the evaluation of amyloid cardiomyopathy. Endomyocardial biopsy is positive in virtually all cases. 1/6 of patients have orthostatic hypotension. Nephrotic syndrome occurs in 1/3 of patients at the time of diagnosis, but rarely during the course of the disease. Proteinuria occurs in 80% of cases, and creatinine levels are greater than 2 mg per deciliter in 20%. Peripheral neuropathy occurs in about 15% of patients. And neuropathy is more sensory than motor and is usually predominantly distal, symmetric, and progressive. Patients with cholestatic jaundice who are few have a poor prognosis. Serum electrophoresis shows a discrete, homogeneous band in half of the cases and hypogammaglobulinemia in a quarter, while the remainder are normal. When serum and urine immunofixation is performed, a M component is found in 90% of cases. The mean number of plasma cells in the bone marrow is 6%. Most patients have a significant increase in serum amyloidogenic free light chains and a abnormal kappa-lambda ratio. Approximately 15% of patients have a deficiency of coagulation factor 10. The diagnosis of amyloidosis is based on the presence of amyloid substance in the tissues. The possibility of primary amyloidosis should be considered in any patient with a serum or urinary M component and any of the characteristic syndromes of amyloidosis. In 90% of patients, a serum or urinary M component is present, or a monoclonal population of plasma cells can be demonstrated in the bone marrow. The initial diagnosis workup will consist of a biopsy of the subcutaneous fat, which will be positive in 80% of cases, If the test is negative, a rectal biopsy is performed, which will be positive in 70% of cases. If these biopsies are negative, a biopsy of the presumably affected organ will be performed. The median survival of patients with AL amyloidosis is between 2 and 3 years and depends primarily on the associated syndrome. Therefore, it is less than 6 months in patients with heart failure, while it exceeds 5 years when the associated syndrome is polyneuropathy. The key prognostic factors are cardiac disease measured by cardiac biomarkers, troponin and NT-proBNP, or by imaging techniques such as echocardiogram and cardiac magnetic resonance imaging, and the amount of free light chains in the serum. The combination of melphalan and prednisone produces a response rate of 20% in patients with nephrotic syndrome without renal insufficiency or heart disease. The response rate increases to 40%. The chemotherapy combination with which the best results were reported was that of melphalan dexamethasone, response rates of 70%, with CR of 30%. It should be noted that in patients treated with melphalan, the actuarial probability of developing myelodysplastic syndrome or acute leukemia after 3.5 years of follow-up is 21%. The new drugs already used in MM, in particular bortezomib and to a lesser extent lenalidomide and pomalidomide, can be very useful in the treatment of patients with primary amyloidosis. In this sense, the most used combination is Cybort, cyclophosphamide, bortezomib, and dexamethasone. Another very promising drug in the treatment of primary amyloidosis is the daratumumab or daratumumab. In fact, a randomized study is underway comparing the efficacy of Cybort to Cybort plus daratumumab. Another option in patients not candidate for autologous transplant is the combination of melphalan, dexamethasone, and bortezomib in patients younger than 65 years without serious heart disease. Treatment with high-dose melphalan followed by autologous hematopoietic stem cell transplantation is the treatment of choice. And I want to mention the characteristics of monoclonal gammopathy of undetermined significance. N component less than 30 grams per liter, medullary plasmacytosis less than 10%, absence of osteolytic lesions, normal hemoglobin level, normal renal function, absence of symptoms attributable to monoclonal gammopathy. Well, with this last part, I say goodbye today. As always, you're welcome to leave me your comments or questions. Thank you for the attention and be very, very well.